Firstly, thanks to everybody. I think it's been really great, firstly, to just get together. It's lovely to see everyone face-to-face as opposed to virtually. It really makes a massive difference, and catch up in the breaks with various people. And thank you so much to our fabulous consumers who really kicked off with a great few points to focus us on the start, and I think that they were really well put, and there were themes coming through in all of the discussions that followed based on our consumer input. So I think just reflecting on what the data shows us from the amazing work that the Tumour Summit team put together in extracting that, we certainly can see some trends toward poor outcomes in the disadvantaged and regional settings. There was a lot of discussion about MDMs and the documentation, and just the communication, getting that that communication both to patients in the form of a care plan, and there's a clear need, I think, from consumers that is, or preference for that to be in a written form that can be taken away with them, but also that documentation and communication back to GPs and doctors within the community who are providing that ongoing support. The supportive care screening as well doesn't come through on how well that's documented, and it will be interesting to see perhaps what impact that's having on patients as well. There is some variation in sentinel node biopsy rates and other surgical indicators such as time to surgery, patient flow to surgery in the local catchment areas as well within the local health services. MDT, we discussed multidisciplinary discussion rates are variable, but I suppose it raises the question as well as what is an MDT? Who should participate in the MDT? Do we need to involve some of our community doctors? Do they in fact have time to participate? Is it a good teaching exercise? And how can we better engage our local GPs in education exercises? And which cases should be discussed? And maybe there's some variation in which cases should be discussed depending on if it's a regional MDT or a central MDT. There are some, as I said, mentioned very good consumer comments, mostly focused around communication and the need to improve communication. And I think our nurse specialists really play a major role in that communication piece and being that point of contact for people when things go wrong or not to plan that they can contact. And so certainly a big push to have more of our fabulous nurse specialists. So the challenges, GP access and education and training, I think that came through fairly strongly, and particularly in regional areas where there are long wait times for GPs. Lack of specialists, and that includes surgeons, dermatologists as well in regional areas, and just that access to being funnelled into an MDT and what's the best pathway and how can we facilitate that. There are some, I think, really good examples of regional MDTs being supported by metropolitan expertise, but perhaps there are some ways that we can advertise that and get that pathway a bit more established within the regional areas. So potential solutions. I think there is a need certainly for some IT and digital solutions for some of these issues around documentation and communication of MDT findings and care plans, both that can be provided directly to patients and that they can take with them to their GP, but then can be potentially uploaded to My Health Record. And I think My Health Record's been in the pipeline for some time, but is not utilised as well as perhaps it could be at this stage. As I mentioned, the Metro Regional Partnerships, I think, are a really good initiative to just support our regional teams and to help with some upskilling exercises as well, and provide some targeted GP education and support. Working on those streamlined referral pathways so that there is a really well-known point of contact within regional settings. They are the notes that I've sort of written down from today. I think there's probably a lot more detail that has come out and some really good recommendations. Are there any sort of burning comments or feedback from anyone in the audience in terms of number one priorities? Maybe should we just quickly whiz around the room and each table the main priority that would come in what we should tackle for the day? Phil, what about your table? Increasing local referrals. Yep. Kathy, what about your hard? Yeah, access. Yep. And documentation. Yeah. I think it's hard, isn't it? Because across the health services there are different platforms being used, and unfortunately we're not all using necessarily the same tools and so on, and so they don't talk to each other, which is really tricky, isn't it? Difficult, yeah. Alison, I'm going to put you on the spot, sorry.
I think patients having care in their own area rather than, not necessarily being sent to a metro area. Yep. If it's pretty straightforward, they're at home, they've got their family near them, and any side effects come up, then it's a lot quickly dealt with. The other thing I want to say is information for patients. There's a swag of information out there. I know the Alfred hands some information packs out to their early and late stage patients, and that would be a consideration for all those in the regional areas, I think, if that could be shared to patients. So to improve their literacy, and then that would give them increased access to supportive care as well. Yeah.
So I wonder, we've all got our own multidisciplinary meetings happening or starting or developing, and I wonder if it's a good idea to have some sort of forum where the chairs of those MDMs can discuss together what information they are providing, what templates they're using and so on, so that there's some sort of standardisation, so we're not trying to reinvent the wheel saying we need to come up with this, information booklet that actually already exists. Table 5.
Yeah, so we were going to work on providing written documentations as they come into the organisation, and do something similar for GPs. Same sort of issues, access in and documentation of patients. So we were discussing having some sort of template for a care plan, noting that each patient is unique and we'll have some nuanced discussion at the MDM, and so maybe there's not a one-size-fits-all, but at least some sort of template that perhaps can be used as a care plan as a starting point.
I think we've talked about what our table's going to do, but what I wanted to finalise with was it's really interesting. We seem to have covered almost the full gamut of the OCP. We've got an early intervention kind of piece here, early referral pathways, provision of information to patients, and then provision of information back to GPs, optimising MDMs. We seem to have covered the full gamut within the room, even though that wasn't necessarily intended. And I wonder if we need to capture all of our learnings in a formal sense, maybe before the next formal tumour summit, so we can all learn from each other, and we seem to have improvements at every step of the way and we learn from.
Yeah, I think I suppose one of the things that summits like this highlight is that having good data is really essential for measuring outcome, measuring improvements, and it is actually difficult to collect some of this data reliably, and particularly, things like MDM discussions or, what is actually documented can be quite difficult to collect. And so I think when we're measuring how much we've improved, we have to think about also how we improve our data collection and measuring.
From the LIMIC's point of view, we've had quite a robust discussion today, and we've had 5 colleagues online as well, so that's been just fantastic to actually bring people together to discuss this. So in summary, obviously the MDM, our MDM has been part of our head, neck and skin MDM, and it meets monthly, so that decision to put to Bendigo Health to have a melanoma MDM, I think is a really important one, and we've had some Bendigo Health colleagues on remote access. I really like your idea of the templates, Tori, because we were talking about that for patients, even if it's, a stage 1 melanoma in a patient's mind, that's sort of unknown and that worry. Whereas if there was templated information and resources for patients to sort of inform them, that's really important. I think workforce has been the other big topic in our area, both from a specialty point of view, as Alex has indicated, but also a GP, that capability building within general practice. And then at a local level, from the LIMIC's point of view, we're really committed to looking at some of the variations in terms of delving deeper and doing some other local audits on the data. So that's, have I missed anything, table? We're all tired as well. Tired but enthused. Yeah, thank you.
That's great. John, did you want to say anything?
There we go.
Yeah, look, I think a lot of really good points have been made. I think it's been a great meeting. I loved the consumer input that we had at the beginning, and I think there's lots of lessons to take home from that. But no, I think it's all been said. I don't think I really have anything important to add. Thanks very much.
Table 9 is the last, I think.
No,
you're good.
We're the worker bees.
You're the work peeps. They're important too. All right, well, with that, I think we'll wrap up today, and I think there are some good ideas of improvements that can be made both within our local ICS as well as across the state working together, and it's great that we can all sort of cross-pollinate a little bit today. So thanks, everyone, for your attention and your input.